Welcome. Thank you for joining us. My name is Dr. Liz Devitt, and I'm with the Purina Institute. I am pleased to be the moderator today for the Cardiology webinar. We are very fortunate to have two renowned experts with us today, Dr. John Bonagura and Dr. Dottie Laflamme, who will share their knowledge and insights, plus practical clinical approaches about the medical and nutritional management of one of the most common canine heart diseases, myxomatous mitral valve disease. But before we start our scientific program, I'd like to take a moment to introduce you to the Purina Institute. The Purina Institute is a global professional organization that serves as the voice of science for Purina, representing a diverse team of more than 500 pet care experts and scientists across a worldwide network of research and development facilities. The Purina Institute believes science is more powerful when it is shared. Through global collaborations, support for pet health initiatives, and conferences and events like this webinar, the Institute shares insights and breakthrough discoveries about proven nutritional science. Nutrition influences every aspect of a pet's life. The mission of the Purina Institute is to put nutritional conversations at the forefront of healthcare conversations about pets. The Institute does not discuss products, only science. With fact-based information, we provide veterinary health professionals like you with the information you need to have nutritional conversations with pet owners that can help pets live better, longer lives. Now that you know more about the Purina Institute, let's turn to our scientific program on the clinical and nutritional management of myxomatous mitral valve disease in dogs. Our first speaker will be Dr. John Bonagura, who will discuss the diagnosis and management of MMVD in dogs. He'll be followed by Dr. Dottie Laflamme, who will talk to us about the importance of nutritional management in canine heart disease. Then be sure to stay with us for the Q&A session, where you can get your questions answered about this topic. Although our speakers are so well known that they probably don't need an introduction, I will give you brief backgrounds about both of them. Dr. Bonagura is a diplomate of the American College of Veterinary Internal Medicine and Cardiology and Internal Medicine. He received his veterinary degree and his master's in veterinary physiology and pharmacology from The Ohio State University. And he currently teaches and practices clinical cardiology at the North Carolina State University College of Veterinary Medicine. Over the next 40 minutes, he'll discuss the findings, diagnosis, staging, and management of myxomatous mitral valve disease, the most commonly acquired heart disease in dogs. After that, Dr. Dottie Laflamme will discuss the importance of nutritional management in canine heart disease. She'll also share new research findings about nutritional intervention for dogs with early stage MMVD. Dr. Laflamme is a diplomate and past president of the American College of Veterinary Nutrition. She received her DACVIM and her master's degree in ruminant nutrition and her PhD in nutrition and physiology from the University of Georgia. For many years, she worked in Purina's research and development with a focus on therapeutic nutrition, especially obesity management, and geriatric nutrition. Dr. Laflamme now works as an independent consultant. With that, shall we get started?
Hello, we're going to consider the diagnosis and management of myxomatous mitral valve disease in dogs today. I'm very pleased to be here representing North Carolina State University College of Veterinary Medicine, where I'm a member of the Cardiology Service. I'm also a professor emeritus of the Ohio State University, as well as having some other positions that relate to cardiology. I'm very grateful to Purina and the Purina Institute for sponsoring this lecture. So we're going to consider a number of topics today. The first will be the pathology of myxomatous or degenerative valvular disease in dogs. And then we'll talk briefly about the incidence and then the recognition and the diagnosis of the disease, both clinical and laboratory testing and imaging. I'll give you an overview of some of the clinical outcomes that occur in this very common condition. And then we'll talk about staging of myxomatous mitral valve disease. And then lastly, just summarize the pharmaceutical therapy of myxomatous mitral valve disease based on the DACVIM consensus panel statement and staging. Well, what do we know? We know this is a very common disease. Myxomatous mitral valve disease, also called valvular endocardiosis, is the most important heart disease in veterinary medicine. It's a degenerative disorder characterized by nodular thickening of the mitral valve leaflets. And we can see in this postmortem these thickened leaflets, but we also can appreciate that the endocardium is smooth and glistening. In other words, this is not an inflammation, but it's a thickening of the cardiac, mitral, and tricuspid valves associated with degenerative change. We know that the valve leaflets can appear expansive and redundant, and we often see them prolapse into the left atrium at autopsy and also by echocardiography. And we know that ruptured chordae tendineae are a very common problem with this condition. Now, histologically, this disease is characterized by what is called by pathologists myxomatous change. So this is a deposition of proteoglycans and disruption of the fibrosa of the mitral valve layers. Now, the mitral valve is affected by far the most commonly in dogs, but frequently there is tricuspid valve involvement. And actually, the aortic valve is mildly involved in many cases, but this can only be detected by Doppler echocardiography. There is no obvious murmur. Here we can see an example of one of the major complications of chronic degenerative valve disease. So firstly, we can see this nodular thickening typical of myxomatous change. But if you notice here, there is a ruptured chordae tendineae. And these are extremely common in mitral valve disease. Now, if we look at this echocardiogram, which I'll play in a moment, here's the left atrium, here's the left ventricle, and here's the aorta. You're going to see the mitral valve is flail. In other words, it has lost its support. And you're going to see it evert towards the aortic valve and then move back into the left atrium. So here we can see the mitral valve is flail, and we'll change our position. Here's the anterior mitral leaflet, and now we can see a wide jet of mitral regurgitation. So again, we have a flail leaflet. Here we can see the thick flail mitral leaflet and the wide jet of mitral regurgitation. Now, histologically, we know the mitral valve has 4 distinctive layers. The one closest to the atrium is called the atrialis. Then there is an area called the spongiosa. This is the area of major thickening in myxomatous change. We also have the fibrosa, which is closer to the ventricular layer or ventricularis, and of course, chordae tendineae attached to the valve. Now, what happens in mitral valve disease is there's a marked expansion within the spongiosa. And what we can see here is a disruption of collagen that's especially easy to see on the trichrome stain, and an expansion of a relatively acellular material. And these are the glycosaminoglycans or proteoglycans that are deposited in the mitral valve and cause the thickening and eventually the regurgitation. Now, the pathogenesis of myxomatous mitral valve disease is under intense study. We know there are clearly genetic predispositions. We know that there are certain breeds at very high risk. And we also know that increasing age and in many breeds, male sex lead to a higher chance of having myxomatous mitral valve disease. Now, in terms of the development of this is an area that has been studied by a number of people, and there's some excellent reviews noted in the references on the bottom of this slide. The valve interstitial cells are thought to be extremely important in the pathogenesis of this disease. There are certainly mechanical factors involved, and the endothelium of the valve also appears to have signaling that's important. Regardless of the initial triggers, there's an increase in signaling of serotonin and TGF beta. And this results in increased production of proteoglycans in the valve. Additionally, angiotensin II, metalloproteinases, platelets, and inflammation may all play a role in the development of this disease. Many older veterinarians know they've been taught that bad teeth lead to mitral valve disease. Really, the data on that is very, very weak. And certainly this is not an infection of the valve. But we do know that in many conditions, inflammation makes degeneration worse. So maybe there will be something to be found in the future. Now, eventually, this signaling results in increases in proteoglycans deposited within the mitral valve, an increase in the extracellular matrix, mainly in the spongiosa layer of the valve, and there's disruption of collagen and elastin fibers in the fibrosa. And as a result, the mitral valve and tricuspid valves become thickened, and they change their structure such that they no longer close properly, and regurgitation develops. Now, in terms of prevalence, this again is the most important heart disease in veterinary medicine. We know from early studies, and we also know from more recent studies done mainly in Europe and very large studies, that this is the most prevalent cause of heart disease in dogs and also in general and in specialty practices. Now, there have been estimates, and the estimates do vary, but about 10% of dogs presenting to primary care veterinarians are thought to have some evidence of myxomatous mitral valve disease. Myxomatous mitral valve disease accounts for about 70% of all canine heart disease in general practice. It would be slightly less than that in a specialty practice, but even there, we see many cases. For example, in our own practice at North Carolina State, we probably see at least 600 dogs per year, at least, who have myxomatous valvular disease. We know that increasing age increases the incidence, and there are strong breed predilections. So let's talk about the recognition and the diagnosis of myxomatous mitral valve disease in dogs. Cardiac auscultation is the practical way that we as veterinarians recognize myxomatous mitral valve disease. And what we can see is that the mitral valve will create either a murmur or a click. If you look to the right, you can see the arrow is pointing to a prolapsing tricuspid valve. And prolapse of the tricuspid or the mitral valve will often lead to mid-systolic clicks that could be heard well on the left or on the right side. These are often misdiagnosed as gallop sounds. I can play for you a click. Notice the click comes and goes and changes. And you can see why these are frequently misdiagnosed as gallop sounds, but they're really systolic sounds of valve prolapse. Now, the most common feature that we hear is a progressively louder systolic murmur. This will usually be loudest on the left, where the mitral valve is, and at the apex, because the mitral murmur radiates to the left apex. We'll often hear murmurs on the right. These may be tricuspid regurgitation or radiating murmurs of mitral regurgitation. In general, if there's a louder murmur on the right, if it is a different frequency or pitch, or if there's a palpable vibration or thrill, it is probably an independent tricuspid regurgitation murmur. Now, the typical murmur of mitral regurgitation will be so long and loud that it may obscure the heart sounds. So here's a holosystolic murmur of mitral regurgitation. Now, again, this disease is most common in older dogs and usually smaller breed dogs. The greatest risk is clearly with the Cavalier King Charles Spaniel, although the Shih Tzu and the Dachshund are often affected very often. Now, again, auscultation is really the key to diagnosis. We have a number of very nice studies comparing auscultation between observers and looking at color Doppler verification of auscultation. And the simple point is that auscultation is the most practical screening test for clinically relevant valve disease. Now, you may see research studies that look at color Doppler, but my perspective on this is that these are research studies. There's no logical reason to screen dogs for myxomatous mitral valve disease unless you're conducting breeding trials or research. So our stethoscope is the practical way to recognize this disease. Many people ask, is there a correlation between murmur intensity and severity? And I would say yes, to some degree, there is. Certainly very soft murmurs are usually associated with mild disease and very little, if any, remodeling. These are localized murmurs that are very soft. Conversely, really loud murmurs, grade 5 or 6, murmurs that are thrilling or have a precordial thrill, are largely always associated with some degree of remodeling. But having said that, you can have a moderate murmur that radiates and the dog can be fine for another 2 or 3 years. And you can have a moderate murmur in a patient who has congestive heart failure. So while there is a general statistical trend towards a louder murmur, you cannot tell if a dog needs therapy based only on the loudness of the murmur. Having said that, a very soft murmur argues against significant remodeling or enlargement at this time. The other point that's a bit of a corollary is we see many small breed dogs with respiratory signs, especially cough. And remember that in a small breed dog with respiratory signs but no murmur, it is very unlikely that this dog is in congestive heart failure. Heart failure is a syndrome. You have to have a disease before you can have heart failure. So unless you're going to diagnose dilated cardiomyopathy, it's very hard to make a dog, especially a small breed dog, have heart failure without the presence of a cardiac murmur. Now, how do we verify myxomatous mitral valve disease? Well, here you can see an example in this echocardiogram of the left atrium, the left ventricle, and we can see a very thickened mitral valve. In the close-up, you can see a ruptured chorda tendineae flipping back into the left atrium. And we can verify the regurgitation either with our stethoscope or with color Doppler imaging. Here we can see a turbulent green signal of mitral regurgitation. We can also see in this patient substantial left atrial enlargement and a very rounded and dilated left ventricle. Now, practically, most veterinarians are going to assess the severity of this disease based on radiographs. And what we know is that chronic mitral regurgitation will lead to progressive left atrial and left ventricular enlargement. Now, we know that this is a very slowly progressing disease. For example, this is a dog who had a grade 3 murmur, but it took over 2 years to develop a heart of this size. We can see the very prominent left auricle. We can see the enlarged left atrium, and we can see the very elongated heart due to left ventricular enlargement. Yet this dog is still not in congestive heart failure. So it's often 4 or 5 years from the first onset of a heart murmur until we see so-called symptoms of heart failure. And also remember that the most rapid increase in heart size occurs about 6 months before the onset of congestive heart failure. And this has been well shown by both studies of Peter Lord and his colleagues, as well as by the EPIC clinical trial data. Now, another way we can look for changes in heart size is to use a blood test, a biomarker. Remember that the heart is an endocrine organ, and when the left atrium or left ventricle are stretched, they release peptide hormones called A-type and B-type natriuretic peptides. As their names say, these cause sodium diuresis or natriuresis, and they cause vasodilation. Think of them as the opposite of the renin-angiotensin-aldosterone system. So with suitable stretch, there will be genetic changes that result in the formation and release of B-type natriuretic peptide from the ventricle. Now, within the blood, an enzyme, furin or corin, splits this into an active hormone and an inactive nitrogen fragment. And this nitrogen terminal of the prohormone is what we measure in the blood. So this is the non-biologically active biomarker that you would measure when you record an NT-proBNP or a BNP test in a dog. Now, the active hormone, the carboxy end of this peptide, is actually going to have the natriuretic and vasodilator effects. Now, this hormone is broken down by enzymes that are often called neutral endopeptidases, like neprilysin. And there are now drugs and even small canine studies that look at the drug sacubitril and related drugs that actually inhibit this breakdown of natriuretic peptides. And this may be a future therapy. Now, while natriuretic peptides clearly increase as a risk for heart failure, you have to be careful. This is a Cavalier King Charles Spaniel with a grade 5 mitral murmur and just an occasional cough, but a normal sleeping respiratory rate. This dog's NT-proBNP is far over the upper limit, which is often published at about 800 picomoles per liter. This dog was over 3,000, yet is not in congestive heart failure. So think of this biomarker as a risk factor, indicating a risk for cardiac enlargement, a risk for congestive failure, but you cannot treat or diagnose congestive heart failure conclusively based only on a natriuretic peptide test. Now, other diagnostic tests have their role. Now, in a dog who has normal sinus rhythm on auscultation, an electrocardiogram is going to be of minimal value. However, in patients with arrhythmias that often complicate myxomatous mitral valve disease, such as premature atrial beats, focal atrial tachycardias, or atrial fibrillation, which we can see here in a dog with an irregular rhythm, no P waves, and very large voltages typical of left ventricular enlargement, we know that an electrocardiogram will be needed to define those heart arrhythmias. And they also have therapeutic implications because in atrial fibrillation, we will still consider using digoxin if renal function is satisfactory. And we may need to use diltiazem, the calcium channel blocker, to slow conduction down the AV node in order to get heart rate control. Now, blood pressure is also important. We know that when blood pressure is high, that it increases the left ventricular pressure, and that in turn increases the left atrial pressure. So measuring blood pressure non-invasively is very important in these patients. Many of them have chronic kidney disease or Cushing's disease, and these comorbidities are a risk for systemic hypertension. There are also therapeutic implications. In patients with elevated blood pressure, probably an ACE inhibitor or an angiotensin receptor blocker would be indicated therapy. And if that's not sufficient, you may need to use a more direct vasodilator, such as amlodipine or hydralazine, to control blood pressure, especially in patients with congestive heart failure. Well, what are the clinical outcomes of myxomatous mitral valve disease? Well, these include enlargement of the heart, which we generally call remodeling today. There are different stages of heart failure that can progress to congestive heart failure. And then we have other comorbidities and complications, both of the disease and other conditions that can affect the heart failure state. So first, let's look at this in perspective. Borgarelli showed that the 6-year mortality of preclinical disease was only 10%. And he wrote that preclinical myxomatous mitral valve disease represents a relatively benign condition in dogs, and further emphasized that stratification based on clinical and echocardiographic findings is helpful in determining treatment. I think we would all agree with that. Not every dog should be on medicine, and you certainly do not treat a dog simply because it has a murmur or a louder murmur. Those are not indications for treating. So what we have to look for then are remodeling or early signs of cardiac dysfunction. Now, remodeling really means cardiomegaly, but there's also changes in the myocardium and valvular tissue and even in heart function that are very difficult, if not impossible, to measure in primary mitral valve disease. We also see patients with heart failure, but without congestion. The problem is, what's the most sensitive sign of heart failure? it's probably reduced exercise capacity. And most clients miss this. They simply attribute it to their dog getting old or osteoarthritis or some other reason. But importantly, remodeling provides us a window for therapeutic intervention to delay the onset of congestive failure. Now, we know that once congestive heart failure has manifested, pulmonary edema will occur, and left-sided failure is more common than right-sided failure. We also know that many dogs develop pulmonary hypertension either from passive backup of pressure or from independent pulmonary arterial change. Dogs with severe pulmonary hypertension have profound exercise intolerance. They often collapse or faint with exercise, and they may have ascites. We also see arrhythmias such as atrial arrhythmias that I previously showed you, bronchial compression from a large left atrium, and even patients who come in shock with pericardial effusion or even acquired atrial septal defects from rupturing their left atrium. Well, here's an example of the remodeling that we can see. This is a dog with severe mitral valve disease. Here's an apical view and a long axis view. You can see the marked increase in left atrial size. And I think in this apical view, you can see the left ventricle also appears to be very dilated, though the image is somewhat foreshortened. You can appreciate the dilated pulmonary veins. And you can also see that the tricuspid valve is prolapsing here and here. So we clearly have evidence of valvular disease and remodeling by echo. We also know that the radiographs are very important for staging, especially in general practice. And everyone should be familiar with performing a vertebral heart sum or score. And we know that this is done by taking the length of the heart and the width of the heart, and then comparing it to the number of vertebrae, starting with the fourth thoracic vertebrae. And when we add up the length and the width, we wind up with a vertebral heart sum. Now, there's a great deal of breed variation with vertebral heart size. So it's very challenging to just use a value for all breeds. Most importantly, I think, is shown here from this study from Lord. Notice how over years, there is very little change in the vertebral heart sum. But then right before the dogs develop congestive heart failure, there's this sudden increase in vertebral heart size. And that's why serial radiographs can be very helpful in practice for predicting who needs therapy and also who's likely to go into congestive heart failure. And a general recommendation, this is my recommendation based on reading the data, not from Dr. Lord specifically, but if you have a 0.1 vertebral body change per month, that is a high risk for congestive heart failure. So if, for example, you changed one vertebral body over 10 months, that would be a dog at very high risk for heart failure. Now, we also know that echocardiography is a standard for not only diagnosing or confirming, but staging heart disease. And we know that if you measure the left ventricular cavity size by 2-dimension or by M mode, or if you measure the left atrial size, especially if you compare it to the aorta, we know that both left atrial and left ventricular size correlates to remodeling. And in the EPIC clinical trial, a left ventricular dimension that was normalized to body weight and equal or exceeded 1.7 was a high risk for benefiting from pimobendan therapy. In other words, these dogs would be treated with pimobendan. And these same dogs had a left atrial to aortic ratio exceeding 1.6. I am much more in favor of this because this is easier and more consistent to measure. This often has different angles going through the left atrium, and so the variability is much higher. I would never just use one of these. I would always use both of these to decide if I was going to start therapy. And remember that the heart function won't help you. It's almost always hyperdynamic in dogs with mitral disease. Now, what we know from the EPIC clinical trial is that there was a benefit of pimobendan to delay congestive heart failure. And here are the criteria. These dogs were 6 years of age or older. They were small breed dogs, less than 15 kilograms, and they had a moderately loud heart murmur, which means you could hear it readily and it radiated to more than one area. usually to the right side as well. The two-dimensional echo was done and had characteristic valve lesions that I've already shown you. I think even people with basic ultrasound skills can see this quite readily. Color Doppler was used to confirm auscultation and the presence of mitral regurgitation, but practically speaking, I think you can use your stethoscope if color Doppler is not available. And then they looked at remodeling based on what I just showed you, the left atrial to aortic ratio and the normalized left ventricular ratio. There was also a vertebral heart sum entry point of more than 10.5. I crossed that out because that should not be used. That is not sufficient. Many normal cavaliers have a heart with that vertebral heart size. Now, one alternative, which I'll talk about in a second, is using the vertebral heart score velocity if you cannot perform echocardiography. An option will be to look at changes in vertebral heart score. Now, the therapeutic impact of this study was you start vetmedin. If all of these characteristics are fulfilled, you would start vetmedin. And this had a substantial delay, which I'll show you in a moment. Now, what are alternatives when echocardiography is not practical? We all know that many of our clients will never have an echocardiogram done for their dog. Well, we can measure the vertebral heart size, and we can also measure what's called the vertebral left atrial size or score, and that is done by measuring from the top of the caudal vena cava to the carina, to the base of the carina. And what we know from a couple of studies by Poed and colleagues at Penn and by Steppen and colleagues at Wisconsin is that if a VHS is less than 10.8, it's very unlikely to fulfill EPIC criteria. Whereas if it's more than 11.5 to 11.7, it probably will fulfill EPIC criteria, and that might be a dog more likely to be started on therapy even without an echocardiogram. The vertebral left atrial score is very helpful to identify left atrial enlargement. If it's more than 2.3, it's probably slightly enlarged, but 2.8 to 3 are much more specific vertebral left atrial scores for correlating to moderate left atrial enlargement. Okay. Now, in terms of outcomes, we know that in addition to remodeling, patients develop congestive heart failure, as you can see in this Afghan. Now, what we know is that if clients monitor the sleeping or resting respiratory rate, that rates of less than 25 when sleeping are good, and even 30 are probably acceptable. But when they're over 35 per minute when they're sleeping or there are upward trends, they're more likely to be developing congestive heart failure and pulmonary edema. This will be recognized by us as cardiomegaly, a large left atrium and left ventricle, and this is where vertebral heart size and vertebral left atrial score can be helpful because this is a very deep-chested Afghan, and we don't see the trachea that elevated, but this dog has a very large heart. We can also see pulmonary vascular prominence here, a dilated pulmonary vein, and we can see pulmonary infiltrates that are compatible with pulmonary edema, remembering that in acute pulmonary edema, they can be very widespread. We can also recognize pulmonary infiltrates with ultrasound. Here you can see what are called B lines or lung rockets. And these are because fluid and air together become a generator of ultrasound that is non-attenuating into the far field. We know from studies and the Vet Blue study that if you see single B lines, that these can be normal, but the more B lines you see, the greater the likelihood that this patient has an interstitial alveolar type syndrome of increased pulmonary density. And this is certainly not specific for congestive heart failure, but it is certainly suggestive with other clinical signs. Recent papers have looked at this and have verified the point that you need to still take chest radiographs to be sure of congestive heart failure in many cases. We also see as an outcome pulmonary hypertension. Here you see a dog with ascites from right heart failure. This dog has an eccentric jet of tricuspid regurgitation, and if we sample it, we can see there's high velocity. This is actually after therapy in this dog. And one of the things that we know about ascites in this disease is it often occurs from a combination of tricuspid regurgitation, pulmonary hypertension, and often atrial fibrillation. These three things are very likely to lead to ascites. And the therapeutic principle is that phosphodiesterase 5 inhibitors are often prescribed if pulmonary hypertension persists after initial therapy for left-sided heart failure. Here are other complications. Here we can see a dog with a very large left atrium and has bronchial compression. The left bronchus is compressed. Here's an old bronchoscopy that I did from a different dog. And you can see that the right bronchus is open, but the left bronchus is compressed. This dog also had chronic bronchitis, which is very common in this as a comorbidity in this condition. And here we see a dog with an echogenic pericardial effusion. This echogenic pericardial effusion has resulted in compression of the heart and shock. So the therapeutic complications here or indications are that we know we can reduce heart size with pimobendan and furosemide. This will sometimes help coughing due to bronchial compression. We know that sometimes we just have to resort to respiratory medicines for severe coughing like prednisone, hydrocodone, or other cough suppressants. And thirdly, sometimes we need to remove pericardial blood, especially in hypotensive patients who have a ruptured left atrium. And we've sent many of these patients home with ruptured left atrium, but you must recognize the condition. They usually come in collapsed, hypotensive, and with a softer murmur than they had before. Well, lastly, let's look at the 4 stages of myxomatous disease and how we treat them. So dogs in stage A are dogs who have a risk of having myxomatous mitral valve disease, but have no evidence of disease. So any small breed older dog would be at risk. Stages B1 and B2 are dogs who have mitral regurgitation, but no clinical signs of heart failure. Stage B1 are dogs who have insufficient remodeling to justify therapy. So either their heart size is normal or there's not enough remodeling in order to justify therapy. And dogs in B2 have enough cardiomegaly sufficient to treat based on clinical trial evidence. Dogs in stage C are similar to the Afghan I just showed you. They are in congestive heart failure. And dogs in stage D have chronic heart failure that is non-responsive to standard twice daily dosing of common medications. So how then do we treat these pharmacologically? Let me just provide a summary if I can. So first, we know that there's a great deal of controversy in asymptomatic stage B disease. One study of cavaliers with enalapril showed no difference between placebo and the onset of congestive heart failure. These are survival curves, but they're actually related to the development of congestive failure, and you can see there's no difference. The vet-proof trial took different breeds and perhaps more severe disease, but also found only a marginal benefit of enalapril versus placebo, a 4-month delay in heart failure with over 2 years of therapy. The more recently published delay study looked at more combined RAS inhibition with spironolactone and benazepril, a drug that you probably know as Cardalis. And what they found was that if you looked at the primary endpoint of developing congestive failure or early cardiac death, again, these are dogs with stage B2. They're not in congestive failure. ACE inhibition with benazepril and spironolactone did not delay the onset of congestive failure, though there was some potential for less remodeling. And importantly, pimobendan was not included in this study, so we don't know how the combination works. The EPIC trial, though, was very positive. This was a study of dogs with stage B2 mitral valve disease who received either pimobendan or placebo. And what you can see from these survival curves, again, to the endpoint of congestive heart failure or unexplained or sudden cardiac death, was that pimobendan had about a 15-month extension in the time to the development of cardiac-related disease. So these dogs remained asymptomatic without clinical signs for 15 months longer, about on average, when they were taking pimobendan. So what about the stage C dog? this is quite straightforward. These are dogs who receive sedation with butorphanol, intravenous furosemide, oxygen, pimobendan, initially in our practice 3 times a day, and then to the standard label twice a day, and might even receive vasodilators. These dogs are life-threatening heart failure in many cases and require fairly vigorous hospital therapy, although some earlier cases can be treated readily as an outpatient with an injection of furosemide and starting oral therapy. In cases that require aggressive therapy, we may more sufficiently either afterload or preload reduce either with topical nitroglycerin, with hydralazine or amlodipine, or very aggressively with nitroprusside or nitroglycerin. These will reduce filling pressures by dilating veins and also reduce the load on the left ventricle. There are very few clinical studies looking at the efficacy of these drugs, but many hospitals will use these for life-threatening fulminant pulmonary edema. Here's an example of a dog with life-threatening pulmonary edema. You can see the diffuse pulmonary infiltrates, and 18 hours later, with aggressive therapy that included nitroprusside, this dog was stable and was eventually able to be released from the hospital. When there's severe pulmonary hypertension as a comorbidity, these dogs will usually present with ascites, and in that case, we will do abdominocentesis to relieve tense ascites. And if we demonstrate protracted pulmonary hypertension that is severe despite therapy for left heart failure, we will provide either sildenafil or tadalafil in order to reduce pulmonary vascular resistance. But we usually in our practice first treat dogs for left heart failure if that has not yet been done. And then lastly, what is the home therapy for heart failure? I tell my students dogs are for special people, and that indicates diet. And of course, what we do is in early stages of heart disease, as the heart remodels, we certainly start to think about dietary changes and reducing sodium. And dogs that are in heart failure will be given restricted sodium diets and high protein diets. I'll have a colleague talk about that. We give ACE inhibitors in our practice. We give furosemide. We give spironolactone. We give pimobendan. But having said that, there are varying levels of evidence. There are strong levels of evidence for pimobendan and furosemide, and there are much weaker, some would say insufficient evidence for ACE inhibitors and spironolactone. I think the problem that I see is we do not have a sufficient trial that combines all 4 of these treatments to see if they are superior to any 2 or any 3. Those studies are not really available. And in terms of practicality, depending on where you live, these drugs can be very inexpensive or very expensive. So that will often modify the therapeutic approach in general practice. So lastly, if we look at the key drugs to treat this disease, we know loop diuretics like furosemide and torsemide will treat active congestive failure, reducing edema and effusions, and also prevent them. In stage D, advanced heart failure, we switch to torsemide, and you always have to follow renal function versus the severity of congestive failure. These are a balance between the two in deciding on the dosage. Pimobendan is a potent inodilator. We start it in stage B2, and we continue it all the way through stage D. We often increase the frequency and dosage as an extra label treatment in stage D congestive failure. Spironolactone, and this should be an ACE inhibitor, spironolactone is used for neurohormonal protection. It also prevents potassium loss, and it may have incremental value. And the same is true for neurohormonal protection with the ACE inhibitors that are often combined with spironolactone, such as enalapril, benazepril, ramipril, and quinapril. But I think we need more data on these drugs, and especially on the dosing of ACE inhibitors to see how much incremental value they may provide. So I've tried to provide an overview of myxomatous mitral valve disease in terms of the findings, the diagnosis, the staging, and the management. I certainly do appreciate your attention, and I thank you for watching this video, and I will take questions at a later time. Thank you so very much. Have a good day.
Hello, I'm Dr. Dottie Laflamme, a veterinary nutritionist, and I'm here to speak to you about nutritional management and canine heart disease. Before we start on heart disease, I want to cover something a little bit more broad, and that's meeting the goal for nutritional management for all your patients, dogs or cats, horses, cows, whatever it might be. The first and foremost thing with the diet is to meet the nutritional needs, in this case of the dog or the cat. That means providing complete and balanced nutrition, enough calories and protein to maintain body weight and body condition, as well as lean body mass. Once you've met those needs, then we can move on to think about managing the clinical signs caused by disease. In some cases, we might even be able to slow or prevent progression of the disease with the overall goal to maintain or enhance quality of life in these patients. So moving on to talk about heart disease in particular, I want to start by sharing the American College of Veterinary Internal Medicine Consensus Committee's nutritional guidelines based on the stages of mitral valve disease and heart failure. So these stages run from stage A, which is an animal who has no evidence of heart disease, but is at risk either because of breed, genetics, or some other predisposing situation. A dog in stage B1 has very, very early changes, but they're very minimal. Stage B2, we have more changes. We're starting to see some changes in the heart, but there's no clinical signs of heart disease in the B2 stage. Stage 3 would be a dog in congestive heart failure. Stage 4 would be more advanced heart failure. According to the ACVIM guidelines, nutritional management is an important consideration, but starting at B2 with mild sodium restriction, and also assuring that calories and protein are adequate to maintain optimum body weight to help reduce any risk for cachexia, manage obesity, things of that sort. And they suggest a highly palatable diet because animals that are starting to have disease may have problems with food intake. But they really focus on nutrition when it comes to stage C and D, the more advanced conditions, where they suggest modest sodium restriction, so slightly more sodium restriction than at B2. But their focus is really on preventing cachexia, maintaining adequate protein and calorie intake with a highly palatable diet, and also adding omega-3 fatty acids, which not only have anti-inflammatory benefits, but may have some benefit in terms of managing cachexia, and also monitoring any excesses or deficiencies and making adjustments accordingly. So let's talk about sodium and some of these other nutrients. Let's start with sodium because that's often the first nutrient that comes to mind when talking about heart disease. Sodium, of course, is the primary osmotic agent in the extracellular fluid, so it drives blood volume. Where sodium goes, water follows. In healthy dogs, the balance of sodium and with it the associated water is controlled through the renin-angiotensin-aldosterone or RAS system. As the heart fails, systemic blood pressure can drop, and the body attempts to increase this blood pressure by increasing sodium retention and water. The problem, though, is this is often overshot, and that results in fluid overload, edema, or congestive heart failure. In dogs with heart disease, low sodium diets have long been recommended. And it has been shown in a few studies that these dogs, so dogs with congestive heart failure fed a low sodium diet, do show some decrease in heart volume. But the problem with the very low sodium diets is that they tend to induce electrolyte abnormalities, specifically hyperkalemia. The other thing about sodium that's more recently recognized is that low sodium intake triggers the RAS system in order to retain sodium. Problems with that is that prolonged RAS stimulation promotes inflammation and oxidative stress, as well as renal glomerular damage and vascular damage. So in dogs with heart disease, a low sodium diet actually stimulates the RAS earlier and more severely compared to dogs fed with normal or moderate or even high sodium diets. And multiple studies in humans suggest that excessive restriction of sodium actually increases cardiac mortality. So what is too low in dogs with congestive heart failure? Unfortunately, there's no controlled studies to determine optimum levels. But from among the studies that have been done, the too low level would be 13 to 27 milligrams per 100 kcal, or 0.05 to 1 to 0.1% sodium on a dry matter basis. At this level, they have identified early activation of the RAS system, worsening of clinical scores, and evidence of oxidative stress due to the RAS. Also, electrolyte abnormalities and decompensation and azotemia when these low sodium levels were used along with diuretics or ACE inhibitors. Other studies used a moderate sodium intake around 40 to 70 milligrams per 100 kcal, which is about 0.2 to 0.25% on a dry matter basis. At this level, there were no adverse effects observed, even when used with diuretics and ACE inhibitors. So what does this translate to in terms of products on the market? The too low level is fairly consistent with a lot of cardiac diets that are ultra restricted in sodium, whereas the acceptable level is the level typically found in kidney diets or properly formulated heart diets. The other nutrient that we mentioned before was omega-3 fatty acids in heart disease, and very specifically the long chain omega-3s from fish oil, the EPA and DHA, which are recognized as anti-inflammatory. These provide numerous benefits, such as a reduction in pro-inflammatory prostaglandins, thromboxanes, interleukins, and cytokines, a reduction in thrombosis, blood pressure, reduction in arrhythmias, and also reduced risk for cachexia. Calorie and protein intake is critical in our cardiac patients, in part to try to control for or minimize the risk of cachexia as much as possible. One thing to consider is that most of our dogs that have heart disease are older dogs, and they need to have adequate protein for their age as well as for their condition. And older dogs tend to actually need more protein compared to younger adult dogs. So it's important that the diet fed to dogs with heart disease contain at least 25% of calories from good quality protein. Palatability and digestibility in the diet are also important. Many dogs with congestive heart failure may be anorectic, either from the disease or from medications. So highly palatable foods can be important. Small, frequent meals may be helpful. Warming wet foods to body temperature may help as well. Dogs with congestive heart failure also may have decreased blood flow to the GI tract and therefore compromised digestive function. A highly digestible diet may be of benefit. And as previously mentioned, omega-3 fatty acids may be beneficial in the management of cachexia. So those are what the DACVIM has talked about. However, I want to point out that there's other nutrients of importance to heart health that can be very important. We're going to talk about those next. One of these is magnesium, one of the macro minerals that doesn't get enough share of voice. Magnesium is a cofactor in hundreds of enzymes, and it's critical for ATP production, protein production, and cardiovascular function. Low levels of magnesium are associated with greater risk for cardiovascular disease and associated mortality in humans, and mitral valve calcification and prolapse in both humans and dogs. Shown here are some of the many roles that magnesium serves specific to cardiac function. Things like modulation of muscle tone, regulation of blood pressure, anti-arrhythmic benefits, decreases in inflammatory mediators, enhanced mitochondrial function, and decreased free radical production for a reduction in oxidative damage. Free radicals takes us to our next topic, which is antioxidants. So free radicals are produced by normal metabolism, but in disease states, there can be an increase in free radical production and often a decrease in available antioxidants such that it creates an imbalance or oxidative stress. Studies have shown that in both dogs and humans with heart disease, there's evidence of increased oxidative stress, and oxidative stress itself can lead to an increase in inflammatory mediators. So antioxidants are important in heart health. Taurine is another nutrient of importance. It's a beta amino acid, so it's not incorporated into proteins, but serves many functions in the body. Concentrations of taurine are highest in muscle, both skeletal muscle and heart muscle, and some of the functions that are important in heart include maintenance of contractile function, osmotic regulation in the myocardium, mitochondrial function and ATP production, as well as it's serving an antioxidant function and reduction of mitochondrial free radical production. As you're all aware, a deficiency of taurine can lead to heart failure in both cats and dogs. A final nutrient of importance is carnitine or its precursors, lysine and methionine. Carnitine is a peptide derivative. It's produced endogenously or provided in the diet. And one of its very important roles is to serve as a co-transporter for long-chain fatty acids to cross into the inner mitochondrial membrane to be metabolized for ATP production. Normal heart muscle is dependent on fatty acid oxidation. So it's dependent on a source of carnitine to facilitate fatty acid oxidation. Dogs with dilated cardiomyopathy may have a myocardial carnitine deficiency, even if their plasma levels of carnitine are normal, high, or low. Supplementation has been used in dogs, but as far as research to support the benefit of carnitine, there's only very little research, but many anecdotal reports, and it is commonly used to provide carnitine precursors or carnitine for dogs with heart disease. What I'd like to share with you now are highlights from several studies done by a colleague of mine, Dr. Johnny Lee, looking at whether or not supplementation with these nutrients I just mentioned can actually be beneficial earlier in dogs that have mitral valve disease. Starting with a multiple omics study where serum metabolites as well as tissue transcriptomics from dogs with and without mitral valve disease were evaluated. And based on the omics of that, they were able to identify derangements in cardiac energy metabolism and mitochondrial dysfunction, changes in energy substrate shifting away from fatty acids to glucose and other less efficient energy sources compared to the fatty acids. Also alterations in oxidative phosphorylation, reduced ATP production, increases in oxidative stress, and increases in inflammatory mediators. So these are changes occurring in dogs with mitral valve disease and heart failure. And so we developed a blend, a cardiac protection blend of nutrients to address these changes in the diseased dogs in order to compensate for these metabolic changes. So these included the nutrients that we've talked about, antioxidants, specifically vitamin E and taurine, anti-inflammatory nutrients, the omega-3 fatty acids, EPA and DHA, nutrients to provide mitochondrial support, including magnesium, carnitine precursors, taurine, and medium chain triglycerides, as well as an alternative energy source in the form of medium chain triglycerides. So medium chain triglycerides are available as an alternative energy source. They're fatty acids, but they're much shorter than your typical long chain fatty acids. So they're much more easily digested, absorbed across the cell membranes. Using MCT or the fatty acids from those results in a 2 to 6-fold increase in myocardial acetyl-CoA, so an easier energy source, increased beta oxidation of fatty acids at the mitochondrial level, decreased free radical productions, an increase in ATP, and increased contractile function in a hypertrophic cardiac disease model. Medium chain fatty acids are also a source of ketones. The liver can convert them to generate ketones. And both the medium chain fatty acids and the ketones are readily used by the heart muscle in proportion to the concentration available. So while the diseased heart has a reduced ability to metabolize long chain fatty acids, it has no difficulty metabolizing ketones or medium chain fatty acids. So a formulation was created with the cardiac protection blend of nutrients and fed to dogs that had mitral valve disease, stage B1 and B2. This graph is showing you the metabolome of the serum from those dogs at baseline and after 6 months. You can see at baseline, the dogs were all pretty similar. But after 6 months on the diet, they separated completely in terms of their metabolome. Some of these changes were related to the diet, in other words, differences in fatty acids and so forth. But the net of the changes were associated with increased energy metabolism, increased efficiency of fat oxidation, reduction in oxidative stress, and inflammation. Perhaps more importantly is the actual clinical outcome. So this is looking at the left atrial diameter on the top and the left atrium to aortic root on the bottom. And we know in mitral valve disease that the size of the atria is an important marker as the disease progresses. We also know that mitral valve disease is normally a slowly progressive disease. So finding changes within a 6-month window is a little bit surprising, and yet we saw significant differences. What we see in the solid line on both graphs is the control dogs, and the dotted line is the dogs fed the cardiac protection blend. And there was actually an increase in atrial size in the control dogs, averaging about a 10% increase, and a slight decrease in size in the dogs fed the cardiac protection blend, averaging about a 3% decrease. So that significant difference is an important difference. This is showing mitral regurgitation in those dogs based on a scoring none, mild, moderate, or severe. The dogs in the control group are on the left, and the cardiac protection blend dogs are on the right. What you can see is that most of the dogs, the control dogs, did not change, but about 25% of them actually showed some worsening over the 6-month study. Amongst the dogs on the left, only 10% showed any worsening, and about 30% actually improved over the 6-month study. So this is showing progression from ACVIM stage B1 to B2. And again, the control dogs are on the left, the cardiac protection blends are on the right, and showing in black is stage B2, in gray is stage B1. As you can see on the control dogs, there was progression, whereas none of the dogs on the cardiac protection blend progressed from B1 to B2. Again, a significant difference. So based on this study, these studies, I should say, and the ACVM guidelines, when do we want to start dietary management for heart disease? Well, the ACVIM guidelines suggest starting sodium restriction at stage B2. But based on the research that Dr. Lee has published, it actually suggests starting sooner when dogs are in stage B1, and not just restriction of sodium, but providing a complete blend of cardiac protection blend nutrients, including medium chain triglycerides, omega-3 fatty acids from fish oil, carnitine precursors, magnesium, taurine, and antioxidants together. So in summary, this is looking at all the different nutrients we've talked about and the role that they may play in either congestive heart failure or in early stage mitral valve disease. The square box outlines the nutrients that were included in Dr. Lee's research, showing that this combination of nutrients was very helpful in early stage mitral valve disease. The blue boxes are showing nutrients that may be important in congestive heart failure according to the ACVIM. But what you can see from this chart is that these two types of diet for early stage and congestive heart failure are not necessarily exclusive of one another. So the mitral valve diet with that cardiac protection blend with moderate sodium restriction can be appropriate at all stages of heart disease. So when do we start? As early as needed in stage B1 and continue it throughout as much as needed. Thank you very much for your attention.
Welcome. Welcome to our live Q&A with Dr. Bonagura and Dr. Laflamme, who have just shared an amazing amount of expertise with us on MMVD, which is just such a common disease in practice. I hope that you all have learned a great deal and something to take to practice with you. We have a lot of questions already in the live Q&A. If you haven't had a chance to put them in the box below the video screen, please do, and we'll get started because there are a lot of questions for us. So the first one, I think, is for Dr. Laflamme. It is, are all the nutrients in the cardiac blend equally important, or could you just give medium chain triglycerides to dogs at risk for MMVD, like the Cavalier King Charles Spaniels?
Thanks. That's a good question. We haven't, in our studies, tested the individual nutrients. Rather, based on the omics study that identified the changes in metabolism in the diseased dogs and in the diseased heart, we put together a combination of ingredients that we thought would address the various changes. In our opinion, they're all equally important. We certainly know that the MCT provides an alternative energy source. The omega-3s provide an anti-inflammatory effect. The magnesium is critical for heart function. Taurine and carnitine precursors are critically important. So all of these, the antioxidants, they all serve a role that combined helps the heart. And let me just say, not only for the specific MMVD, is some of these nutrients would also have more or less benefit with perhaps other forms of heart failure or more advanced heart failure.
I'm going to follow that with one more question about nutrition, and then we'll switch over to Dr. Bonagura. Does the cardiac protection blend includes methionine and lysine? Why not just put carnitine in? Why use those precursors? Is there?
Yeah, and that's a real good question. There's several different reasons, but one of the easiest ways to look at it is we also know through other omics studies that dogs with mitral valve disease are they have low levels of blood methionine. So their blood is deficient in methionine compared to healthy animals. So by providing the methionine, it helps to address that issue. But in addition, it allows the dogs to make their own carnitine as needed, provides methionine is also a precursor to taurine in dogs. And we know that both carnitine and taurine have their important roles. And lysine also provides many benefits. So yes, you could just use taurine and carnitine, but then you're not addressing that methionine deficiency. And the other thing is the dogs with myocardial disease that have shown myocardial carnitine deficiency quite often don't have a total body carnitine deficiency. They just have an inability to get it into the heart. And so adding carnitine to the diet really doesn't address the needs of these dogs with mitral valve disease.
Thank you. And the next question is for Dr. Bonagura. You mentioned that dogs with myxomatous mitral valve disease, many of them can also have tricuspid valve disease.
Well, I think we're losing.
Dr. Bonagura,
moderator.
I think you're on mute.
We kind of lost the question there, Liz. You were asking about tricuspid disease?
I'm sorry, I was. The question is, does having tricuspid valve disease and MMVD increase the rate of heart disease progression?
It depends. It's a great question. I actually wish they had not named it MMVD, but they had named it just myxomatous valve disease, because if you look at echocardiograms, clearly the tricuspid valve is very often affected. We often see septal tricuspid valve prolapse, and you'll often see an eccentric jet of tricuspid regurgitation directed towards the lateral wall, which can lead to quite a loud murmur. I think you have to look at the size of the right heart and whether or not there's significant pulmonary hypertension with it. The dogs who have the most severe tricuspid regurgitation usually have either atrial fibrillation or pulmonary hypertension or both. For the most part, the right heart is relatively small in the majority of dogs, and they do not have ascites. But whenever I see a dog with ascites, I usually think of a dog who has significant tricuspid regurgitation, but they typically also have pulmonary hypertension, or they have atrial fibrillation, or both. And so I think the answer really depends on the concurrent conditions. Most dogs, I would say, it's of minor importance, but may contribute to the murmur.
Okay, thank you. And I'm going to stay on that line of questioning for you, Dr. Bonagura. What is the perspective of echocardiographic examination with strain? Is there any information about this method for dogs, webinars, articles? And I think many of us need to know what strain is.
Yeah, I was going to start with that. So that's an excellent question. And actually, I pulled a couple of references when I saw this question pop up, and I think they will deliver those to the chat or to the Slido eventually. So there are references. I would say that from a practical perspective, the use of what's called myocardial deformation or strain is of very little importance right now. So strain is how much the myocardial segments deform between diastole and systole. And because the heart is three-dimensional, this can occur in three dimensions: longitudinal, circumferential, or radial. And these are generally hyperdynamic in all planes when you look at studies. And the only time they tend to become lower or abnormal is when a patient's in congestive heart failure. And I would argue that's an extremely expensive modality to use to diagnose congestive heart failure, which we would diagnose from respiratory rate, clinical findings, and chest radiographs. So you can look at a number of studies from Sweden that we published in Columbus and also from Japan. And all of these have shown in general that dogs have hyperdynamic hearts, both in diastole and in systole, when they're small breeds with mitral valve disease. And because of that, almost all the functional indices, including strain, are increased. So that's a great question.
Thank you. The next one, I think, is going to go back to Dr. Laflamme. At which stage of MMVD were the studies conducted by Purina demonstrating a reduction in the progression and the full benefits associated with that dietary intervention?
Okay, thanks. Our preliminary data that we based our formula on, the omics study, was done in dogs with B, C, and D, so more advanced stages, to identify the changes in the heart. But our interventional trial, our dietary trial, was done with dogs in B1 and B2, and the majority started the study in B1.
Thanks. So early stage.
Early stage.
I'm going to switch over to Dr. Bonagura for a more clinical diagnostics. What is your TID dose for pimobendan, and what are the highest doses that you would use BID or twice a day?
All right, so if we look at the labeled dose of pimobendan or vetmedin, because that's the only approved product I'm aware of, it varies across countries. The range that was used in the EPIC trial was 0.2 to 0.3 milligrams per kilogram twice daily. Now, I practice at North Carolina State now, and I have to tell you that I've never seen such high dosages used in my life as I have here. I've literally seen a milligram per kilogram 3 times a day. Now, the good news is that it seems to have a very good safety profile. But if you were to ask me what would I do with my own patients practically, I start at the label dose, which in the US is 0.25 to 0.3 milligrams per kilogram orally twice a day. When my patients start to deteriorate, or especially if they cannot tolerate diuretics and they become more azotemic, I usually increase that frequency to 3 times a day. So they may be getting, for example, 0.9 or even 1 milligram per kilogram per day divided in 3 doses. Now, have I seen higher dosages used? I absolutely have. I honestly, I don't have a problem giving a half of a milligram per kilogram by mouth 3 times daily to dogs. They will tolerate it as far as I can tell. Having said that, these are extra label dosages, and you should advise your clients that you're using extraordinarily high doses compared to the label. But there is a great deal of experience using high dosages. And we use 3 times a day dosing for acute heart failure in the hospital. And then as heart failure worsens, we go to 3 times a day dosing. I try to stay within the labeled dosage 3 times a day, but I will go higher. So it's a great question.
Thanks. I'm sure clinically that will be super helpful to a lot of folks on the webinar. What are the prospects for genetic screening, more particularly concerning Cavalier King Charles?
Right. Well, so I'm not a geneticist, but what I would say is, and I did send some references on genetics of mitral valve disease, including Cavalier's, over to the chat and to the Slido. So that should become available. But there have been some studies looking at genetic markers and liabilities in multiple breeds, including the Cavalier. But insofar as I know, there is not a commercially available genetic test that you can perform. Having said that, since about every Cavalier gets this disease, I'm not sure that we would be able to readily use genetics to screen the best breeding stock. But at this point, I would leave that to more experts in genetics than myself.
Thank you. Still, one more clinical question to you before we go to Dr. Laflamme. What can we do to track MMVD progression if clients decline X-rays and echo, aside from monitoring the heart murmur intensity?
Okay. Well, assuming a client won't do anything other than let you do a physical examination, what I would say is the responsibility will be on them to start monitoring 3 main clinical signs. One of these will be exercise tolerance, especially if their dog can exercise well. That is the most sensitive sign of heart failure, but because many of these dogs are older and have osteoarthritis or other conditions, this is often overlooked. The second would be coughing. Coughing is a very nonspecific sign, and the vast majority of dogs who are coughing with mitral valve disease are not coughing from mitral disease or heart failure. They're coughing from primary airway disease, either tracheal collapse, sometimes laryngeal dysfunction that's subtle, and most commonly from chronic bronchitis that can include bronchomalacia. So you really have to be very mindful of that. Probably the most useful thing a client can do, and what we tell our clients to do even when we do perform all the tests, is sleeping respiratory rate. Now you can do resting respiratory rate or sleeping respiratory rate. I prefer sleeping respiratory rate because the patient should be calm. They should not be hot, hopefully, and not thermoregulating, because dogs can literally pant while they're sleeping. And so I prefer that they be sleeping. Less than 25 per minute is normal for the vast majority of dogs. Less than 30 is very acceptable. Remember, the lung will become a little bit stiffer when it's congested. And so you minimize your work of breathing by taking more rapid, shallow breaths. So 30 is fine. Over 35 per minute when they're sleeping actually is very worrisome and should prompt at least an examination, especially if the patient seems to be having trouble breathing. Obviously, you'd like to take a chest x-ray to confirm congestive failure, but if you can't, you may need to preemptively prescribe some medication just to see if there's a response to therapy if the client will not allow us to do diagnostic testing. Okay. Sleeping respiratory rate is your friend. It's really, really good and really practical and gets the client involved. There are even apps online where they can monitor their dog's respiratory rate.
Perfect. Back to the nutritional side of things, Dr. Laflamme. The dietary intervention for the early stage MMVD, is that ketogenic?
That's a good question, because people associate medium chain triglycerides with ketogenesis. And I would say that MCTs are ketogenic, but the diet is not what we would consider to be a ketogenic diet. So it's got a certain percentage of MCTs in there. There probably would be a slight increase in production of MCTs, which is one of the things that's providing the alternative energy source to the heart. But the diet doesn't have the other characteristics that we would associate with a true ketogenic diet. It's not low in protein, for example. So MCTs are ketogenic. The diet would not be considered really a ketogenic diet.
Thank you. Still on the nutritional aspects, do we know the impact of this cardiac protection blend on dogs with advanced heart disease? And there's also a question that's been asked several times. And also, is it recommended to use a dietetic food already in dogs with stage A? So,
okay.
The alpha and
So,
the
so we're getting the question from both directions here.
Yeah.
So let me start with the more advanced heart failure. I will say that this formula has not been through clinical trials with dogs with advanced heart failure. However, the nutrient profile of the diet is consistent with both the ACVIM guidelines for advanced heart failure. So it has moderate sodium restriction, it has good protein, good palatability, it's got omega-3 fatty acids. In addition, it has nutrients that have been shown in other studies to be beneficial. For example, the taurine, the carnitine precursors, the antioxidants. So these are things that have been shown in both dogs with more advanced heart failure, different types such as myocardial disease, other species with heart failure. So we know that each of the nutrients in the cardiac protection blend provides a benefit. So while the product itself has not been through clinical trials in dogs with advanced heart failure, it is consistent with a diet that would be beneficial at all stages of heart failure and pretty much all types of heart failure. So let's go back to the question of when should you start this? And I would say the diet itself would be appropriate for any adult or senior pet. No harm in feeding it to any adult dog. However, there's certainly no evidence that feeding it at stage A is going to provide detectable benefits. We know that MMVD is a very slowly progressive disease for the most part, for most dogs. There are exceptions, but for the most part, it's very slowly progressive. Even from B1 to B2 typically takes a while, although we were surprised to see statistical changes in our 6-month study. But to get from stage A to stage B, that can take many years. So there's no harm in feeding this diet, but there's also no evidence that it's going to provide a benefit that early.
Thank you. Our live Q&A is generating a lot of questions, and we've already snuck over the 15-minute timeline for our Q&A, but I think we can extend it a little bit more to get to a few more questions, if that's all right.
Mm-hmm.
The next question is, were the dogs in the dietary intervention study with the blended food also being treated with medications? So
most of the dogs on that study, most of the dogs on that study were not on any kind of medication, but I believe there were 1 or 2 dogs in each of the treatment groups, the placebo group and the control group, that were on pimobendan or other medication. Those that were on it before the start of the study, before they recruited, and were maintained throughout the study. So it did not change during the course of the study. And it was, I believe, not more than 2 dogs per treatment group.
thank you. And that brings us back to more pharmacology for Dr. Bonagura. Torsemide questions. What is your experience with torsemide in dogs with CHF, with resistance to furosemide? And kind of the combination, have you used torsemide as a first diuretic option in dogs?
Sure, those are great questions. So I'll start with the second question first. So torsemide is labeled for veterinary use in some countries, mostly in Europe. I know in the UK it is. In the United States, it's a generic drug, relatively inexpensive. In general, torsemide is approximately 10 times more potent on a milligram basis as furosemide. But the main advantage of torsemide is not its potency, but its bioavailability. So the typical patient that we switch to torsemide will be one who's on a high dose of furosemide. Now, having said that, some clinicians, especially for clients who have trouble medicating their dogs, will prescribe torsemide as the primary medication, and they will do that because it's probably a once daily dose in dogs with mild congestive heart failure. However, in more advanced congestive heart failure, we would use torsemide twice daily. Now, I believe in the proceedings notes I have a dose of torsemide, but it is approximately 1 milligram per 10 milligrams of furosemide. So if, for example, I was giving 50 milligrams of furosemide per day to a dog, I would give 5 milligrams of torsemide per day. Whereas the furosemide dose might be divided into 3 doses, the torsemide would probably be divided into 2 doses. So 2.5 milligrams or 1/2 of a 5 milligram tablet twice a day. We tend to use this at about 8 milligrams per kilogram per day of furosemide. So if a patient is getting Lasix or Salix at about 8, maybe 10 milligrams per kilogram per day, and they're still having ascites or pulmonary edema, we will optimize their pimobendan dose to 3 times a day, and we will usually switch to torsemide directly. We don't even do any transition, we just switch. And so I think it can be more effective probably because of its bioavailability. I think you need to be careful. You need to check their renal function and electrolytes within about 5 days, because if it's more available, it may cause more azotemia or more electrolyte disturbances in some of these patients. Good questions.
Thank you. We have time for one more question, I think, and I'm going to combine a couple. These will be for Dottie with the nutritional aspect. Does the cardiac protection blend have any contraindications? Actually, this might involve you as well, Dr. Bonagura. Is it possible to use for patients? I lost the question, sorry, on the Q&A. So I'll just...
I think the question was, can you use it in patients with early disease? And then there's a similar question that says at the bottom, can you just feed it if you're not sure of the diagnosis, if the dog just has a murmur? Those are the questions, but I'll let Dottie address those.
Yes, so as far as contraindications, there's certainly no adverse effects from this diet fed to healthy animals. We actually did 6-month studies in healthy dogs. Are there diseases for that particular nutrient profile? Maybe inappropriate. That's possible. For example, advanced kidney failure. This diet is not restricted in protein. It's not specifically restricted in phosphorus. So for advanced kidney failure, probably that would be considered a contraindication. In the situation of, there's many other diseases where it would be fine, basically. If you wanted to feed it to a dog that has a murmur, but you don't have a confirmation of heart disease or heart failure, well, you don't get a murmur for nothing. So obviously there's something going on in the heart, but there's no adverse effect to feeding it at that stage. So I think that covers the questions, but if there's more, let me know.
And I read ahead. There are 2 questions about
Thank you.
pharmacology that I could probably answer quickly. The first one was using beta blockers. Beta blockers have not been sufficiently studied. And in the trial that was started, it was a prospective trial. The trial was ended because there was no benefit. And so I would not recommend using a beta blocker unless you're giving it as an antiarrhythmic. And then the other one is there any drug that will delay the progression of the valve disease itself? There are probably anti-serotonin or serotonin receptor blockers that might, but they have very profound side effects. So at this point, I'm not aware of any drug that will prevent the progression of the degenerative valve disease.
Thank you. With that, we are out of time. And I wanted to thank you so much for joining us for this cardiac webinar, Dr. Bonagura, Dr. Laflamme. For those who wish to review this one more time, there's a recording available starting tomorrow in several other languages. And we certainly invite you to visit www.purinainstitute.com for more information on the science of nutrition and certainly about heart health. Thank you so much for joining us today.
Thank you.